Welcome to those, I almost said welcome to those listening on the World Service. That gives me away as somebody who was overseas a lot of my youth. Let's now go into the meeting proper. Minutes of the last meeting. First of all, are people happy that it's an accurate record? Thank you. Matters arising. Sorry, my screen keeps dying on me. Going through the matters arising, there are a number that are in progress, but we are going to be dealing with either in this meeting or in the strategy day in June. One of them is actually that I should provide a written report, and I provided a very short written report this time. I was myself, Sally, others have been trying to work out quite how to do this, and in a way haven't quite found out how to make that work. So we'll work on that perhaps in the strategy board away day and think about how a report from me could be useful without just being a list of, meetings. Yes, any questions about the matters arising? Anything we need to say about them? No, I don't think so. Good. Right. Very. I'm not operating on the one. We're now going to go. Thank you. We're now going to hear about something which I think's really looking forward to this. Thank you, Neil. Will you start off, introduce the rough sleeping and mental health team? Thank you.
So we're doing something a little bit different with the service user involvement piece this month. We thought it'd be interesting to go direct into services rather than from the involved group. At a recent operational review, we heard about the rough sleeping project, and there was a strong feeling that the listening to service users was absolutely integral to the practice in a very interesting way, and a request was made to showcase this in this slot. So we've made a film, and really delighted that both Helen and Maz from the service are able to come along and talk about the process. So I've got a short film, and then we'll put some of the service user comments up, and you can take it from there. Is that okay?
RAMP is, as I say, is the Rough Sleeping and Mental Health Program, funded, is a 2-year initially funded project by the Greater London Authority. And the concept is we work with people who are rough sleeping, and this is separate to people who are homeless, because there is always that confusion between rough sleeping and homeless. We work with very low threshold, people who are presenting with mental health conditions, with or without substance use, and the like. And the idea is that we go out, we assess, and we build therapeutic rapport. The background of our patients, most of our patients tend to have complex traumatic experiences from childhood. And so in a way, really, the system has let them down, so that there is that rupture in relationships. So we try to build that therapeutic relationship and build trust, and then start linking with services, mainly housing, and see how we overcome that.
Majority of our referrals do come from Thames Reach, which is the outreach service, because they've identified this person as rough sleeping and they've got mental health concerns. And then as soon as we receive that referral, we then will go straight out, locate them. We do joint visits with Thames Reach as well. I
think there's definitely numerous factors. For what I've found through working through RAMP is that there is, for every person rough sleeping, a unique story that needs kind of supporting in terms of those variables that the narrative is.
Sometimes it's good to go to the sleep side because it makes them feel comfortable that you're not judging them, that they're happy to, we build the rapport from the sleep side because they know you come to see them, and sometimes they don't want to see you, but once they see that you're at the sleep side, they're ready to, know you're ready to kind of know what is going on. They're ready to trail their mind, and they feel comfortable speaking to you, not taking them to a posh area or something.
So in a really personable way, I think sometimes it's best to meet them at their level, at eye level, and support clients and patients in a holistic way, in a therapeutic way, in a trauma-informed way. A lot of clients that we see, in a public area, we try and take them off the street, take them for something to eat, take them for a coffee, you know, sit down with them, get to know them. And this can be a gradual process, you know, but at the same time, you know, it's so important that we have that personable approach, that we're meeting them, you know, where their needs need to be met, really.
You have to give them time, you know, give them a lot of room to, you know, to accept the support and to, you know, to seek, you know, you can tell they're hungry for it. You don't want to push for them to, you know, to say, I'm just here, because they think all services are just there to tick boxes. You just want to listen to my story and then there you go. But with the team, they really, we're not actually, you know, pushing until we take more time to build that rapport so we can actually, they can trust us.
The most rewarding part of the job is seeing results and seeing people have good outcomes and have somewhere stable to live, you know, and you know, seeing them flourish really and thrive, you know, under so much difficult circumstances really. So I had a client that was living kind of in absolute squalor at one point. She was, you know, bedded down in her flat, you know, and it was a very sad story, you know, surrounding that. We actually managed to support her into a mental health and rehabilitation type service for her, and yes, she managed 6 months away from kind of alcohol, and drugs were part of her story as well. And it was quite breathtaking, like seeing the change in this woman was really an amazing thing. You know, in my years of experience, yeah, there have been lots of success stories that I can think of, you know, with clients, turning their lives around, changing their attitude and their mental health, and you know, flourishing in life generally.
What do the patients generally say? What do you pick up here?
Just the supporting of the medication, having them housed, and like I say, then they start to turn their lives around because they've got everything that they've needed to make that next step.
So we'll be able to circulate the slides. I've got a lot of really good information, but I'm just going to hand over to Helen and Maz, just talk a bit about the sort of listening processes.
Thank you. So on this, we'll talk about the team just listening, spending time with people, getting to know people, and that might take months. It doesn't take one session or 2 sessions. That might take months and months of work, but certainly putting that investment in makes a big difference to people's quality of life. The other quote is about people feeling that mental health services have let them down over the years, and this is the first time that they've felt able to trust somebody to help support. I'm going to hand over to Maz because he's much more closer to the ground than I am on patients.
Thank you. So just following on what my colleagues have actually said in the clip, as Sophie, I think you mentioned it yourself, in terms of understanding people's journey, that's what it is about. It's about, you know, we all have our own stories, we all have our own journeys, and the KPIs, you know, will take care of themselves if we can take care of people. So that's fundamentally what it is. Sometimes it is not, we encounter resistance, and as I said in the clip, you know, because of that, you know, feeling of being let down by services, so to speak, and we understand that. We look at that through the lens of possible traumatic experiences people might have had, you know, in earlier lives. So that's where the trauma-informed care comes in. Fundamentally, obviously, we have our trust values in terms of we are kind, we listen, we fair, yeah, we are fair. I've forgotten the fourth one, but ultimately also is unconditional positive regards. You know, so whatever the presentation, whatever people are, the situation is, you know, we respect them. As my colleague Nikolai said, you know, we go at people's level. I'll tell you something. On Christmas Eve, I was on the floor sitting next to one of our service users, having a chat with them on the floor, and you know, a community service came in and they were giving out goodie bags, and they give our service user one, and they gave me one. And he said, well, he's not a service user, And I said, well, that's all right. So the idea there is that, but I was pleased about that because of all the, the stigma that people go through. I felt that if I was seen as part of this gentleman, and being with him on his level, then at least hopefully he is seeing me, that I'm not coming as an outsider. I'm coming at his level to talk to him and engage with him. And that's how we build that rapport, really. We're very flexible in our approach. We go to our service user, meet them at their sleep sites. Sometimes this involves going out at 6 o'clock in the morning. Sometimes it means going out at 8 o'clock in the evening, just to make sure to do that welfare check and check in with them. Sometimes, as I say, people are resistant and may not want to engage with us. The longest we've had where people are reluctant to engage with us for about a year. We don't discharge, because we try to work with their loved ones, their families, and to hear their concerns. And where there are concerns, unless and until we've done that comprehensive assessment to decide whether actually we need to take them on or not, accept them, then we'll carry on working. We carry on visiting. We try to think outside of the box. Sometimes we bring in special language therapists to come with us. Sometimes we drop in letters and say, we understand you don't want to talk to us, but here is what we do. This is who we are about. If you don't want to talk to us, is there anybody else you would like to speak with? We've gone with visits, joint visits with their family and loved ones or friends, and in terms of the picture that we work with, not only drug and alcohol, which is the majority of the cases we work with, present with, but also in physical health, in terms of scabies, in terms of infected wounds, in terms of people, ADHD is one, and autism. So these are things that we try to cater for all these things. What we do, and the support from Oxleas in terms of services and colleagues and senior management has been brilliant, really. Not only in terms of Helen, but Emma Willing, Catherine Seaborn, Munia, and Janice. Our podiatry service, when we've needed them, they say we are here for you. If we understand people may not turn up, but if you get them and they're willing to come, contact us. We'll see them. Our hubs. So, in terms of the support, really from Oxleas and various teams, it has been really, really brilliant. And I can't thank colleagues, management, and everybody else really enough, and obviously and Helen.
Thank you, Helen and Maz, and thank you as well, Neil, for introducing that. That's really interesting. Is underplaying it. So thank you very much for that one. Thoughts or comments, Abby, and then Rachel.
Thanks very much, Maz and Helen. And Maz, I'd heard your presentation before at the Older People's Conference, and thank you very much to you and your team. I think one thing that you probably are underestimating is in terms of health inequalities, how this is really helping people who are marginalised on so many levels in terms of protected characteristics. And you didn't mention physical health, but the person that presented with you at the Older People's Conference is almost like saving people's lives. Some of the people that had really, really poor physical health that you had to try and engage. So well done to the team. And I suppose when I heard the presentation, it's a case of our services are developed from the point of view of how either politicians or clinicians develop them. I think we need to do more in terms of how do people want to approach or attend our service, which is what this service. And I think that's one thing we need to learn about our services.
So I too was really blown away when I heard you present this previously at an operational review, and really thinking of, you explained some of the complexities about how you maintain that continuity of contact with people who are by their very nature not permanent in terms of their location, and it really, really stuck with me. I also had a read of the HIN report, and it's so positive about what you do, but in there I think there are two areas in particular which were kind of highlighted as holding you back, really, in terms of funding, I think, and in terms of recruitment. And I just wondered, what your ask is, I suppose, of us in terms of those two elements.
Thanks, Rachel. So I think funding across the NHS is really tricky at the moment. We really appreciate that. But I think from the board, we just need to make sure that the profile of the service users, this team, are high on the agenda. I mean, as Maz said, these are people that are living on the streets, in tents, under plastic bags, in really dangerous conditions, and also on top of that have drug and alcohol problems and mental health problems. So I think from a board perspective, is making sure that this client group isn't forgotten about. I know there's priorities across services, but I think we're a very, very vulnerable group. We are looking at how we try and generate some more funding into the service, and Maz has had quite a successful discussion with somebody this week about bringing in some funding short term.
Lisa.
A few questions. I'll start with the baseline one. What is the difference between rough sleeping and homelessness?
So rough sleep, there's a very clear definition about rough sleeping, and it's about, I've got the definition here in front of me, it's people sleeping about to bed down, sitting on or standing next to their bedding, or actually bedded down in the open air, like in streets, in tents, doorways, parks, etc. That is the definition.
So I guess you alluded to this, but how do you maintain contact with that cohort? And then second, do you encounter or have you encountered individuals that are Oxleas patients? So, service users that are in our ICMP team but are not engaging. How often does that happen? And what is the process for that when they're already kind of under Oxleas care, but it's not working?
I can answer that bit. The first bit about how do we maintain contact, it's perseverance. It's getting to know people, continuously going out to sleep sites, working with our partners across the 3 boroughs. There are brilliant partnerships we've developed, or the team have developed, with all sorts of people, GPs, pharmacists, dentists, all sorts of people that can support this client group. And it's about maintaining those links and knowing where people are. We've got an example of a service user who regularly attends a particular job centre. So we've been able to link in with the job centre to make sure that we have contact service user in the job centre, for example. It's perseverance, as Maz said. They go out at 6 o'clock in the morning, 8 o'clock in the evening. I know Maz has been known to go out at weekends, so that's just really going at the level for the service user, because there are some service users who will be away from their sleep site at 6 o'clock in the morning and moved on somewhere else, and we've missed that opportunity. I want to talk about known services.
So in terms of when we first started the service, we were working with people who are rough sleeping under other Oxleas services, and we'll work with them. But the GLA then said to us, for purposes of data and commissioning, we don't know whether now the improvement in mental health and presentation would be attributable to ICMP intervention or to your intervention, and therefore we're advised not to do that. So, but what we'll do is that, and we've come across cases where people, particularly from ICMP, are rough sleeping in other boroughs within Oxleas area of operation. What we'll do is we'll do a welfare check, we'll link up with the care coordinator, we'll book a cab when their depot is due, and we'll take them over for a depot. And we join meeting also with them in terms of what could we do in terms of supporting them also. We do give the feedback. But again, this is something we're hoping to review once the funding from the GLA ends, the Greater London Authority, in the sense that I don't think that makes sense. I don't think personally it makes sense if somebody, for example, from Bexley is in Greenwich, for the care coordinator to be going to Greenwich when I'm out on the street already, or my colleagues, we'll take on and we'll do the work with them and we'll support them, So we have to have that fluidity, this silos work, we will not get anywhere really without breaking down barriers. So that's my hope moving forward.
Yeah.
Thank you. It's really fascinating work and very laudable. I'm wondering what the long-term outcomes are and whether it's possible to measure those.
So one of the long-term outcomes is to make sure that people are engaged with a GP. That's one of our KPIs. So making sure that somebody is engaged with primary care. and they get the health care that they require. That is one of the outcomes, and we've been very successful at doing that with our local GPs across the 3 boroughs. And the other outcome is particularly around sustained accommodation. Now, we haven't got the data around how that's been achieved or not. We have achieved that in terms of making sure that everybody that's discharged from our service is put into some form of accommodation, but we haven't been around long enough to know whether those people have maintained accommodation. There are a few that we know have dropped out of accommodation and come back, but I think that's the ultimate aim, is to make sure that somebody's in long-term safe accommodation and has access to not just healthcare, but all services they need to lead life, really.
And the other point, and this conversation we've started having with local authorities in terms of prevention, so something that one local authorities actually have put some plans into, in terms of making it happen, is they're looking at what could we do to prevent people rough sleep in the first instance, in the first place. And what I've proposed to our partners at local authorities is that, because again, we've had people who are rough sleeping because they've not paid their bills, but they had previously been under ICMP and the like. And what they could do, if they have concern about people's mental health, reach out to us. We'll go and do the assessment. At least we can, rather than send a letter to people and say, you know what, you've not paid your bill, or you're in arrears, sent arrears, and they end up discharging, because it becomes more costly and more expensive to get people back into accommodation. So we want to look at that preventative approach. And I was in a meeting, actually, one of the local authorities yesterday, and again, they've put into that, and that's something in a subsequent meeting in 4 weeks' time, we'll be looking into how to develop that. One local authorities have already allocated a navigator, or they're planning to recruit a navigator specifically to work people who are at risk of losing their home. And the third local authority, I think I'm presenting to them sometime in May also to the same point. And just one final point in terms of joint work and health inequality and so on. So one of the things actually we'll be successful at doing is dental services, for example. People working who are off sleeping to have dental services and so on. This is something we've successfully advocated to one of the local authorities, public health service there, the team, they've picked it up. And now we have actually mobile dental services coming and providing that support for them. We had a meeting last week where we're going to, again, through the regional funding, we're going to have a psychotherapist, because again, looking at the traumatic experiences people have. And we're having conversation with CACT, Charlton Athletic Community Trust. This is an idea I brought from early intervention team when I worked for AIP, in terms of, again, because removing people, improving social network, and removing people from that negative influences, if you wish, in terms of drug and substance use and so on and so forth, giving a positive role model, so to speak. So these are local authorities have been very, very interested in this, and they've been very on board. And in terms of addressing health inequalities, I mean, these are the things that we are really been trying to look outside the box, really, in terms of providing.
Okay, I've got the final question and statement, if I may, or comment, rather than statement, comment on this, if I may. First of all, the comment. I mean, it seems to me that what you're doing is an extreme form of an integrated neighbourhood team. And I'm actually quite interested that we've got quite a few places across the trust where we are running things that look like integrated neighbourhood teams. I think our offender healthcare is another example where we do that. And I just wonder whether there are any lessons that we can learn across those without disrupting what people are doing, because the situation is going to be different. But when there are lessons, because I was slightly concerned to hear that we may be putting up slightly false barriers between services here because of the way in which we're evaluating patients. When you say, Maz, when you indicate that one. So I'm just sort of interested in how is it that we have people who have a specialist knowledge of their location, in that your case, location is a cohort of people, and yet can bring in the specialist services as they're needed, or get advice from the specialist services. That's probably more of a comment. My question goes to how do we, and again, this is something that goes across a lot of our services, especially in the community, how do we support our staff doing this one? Because, as you talk about, you're doing the stuff in the evenings, you may be doing stuff at the weekends if that's what's needed. And that speaks a lot to your dedication. How do we support our staff to live their dedicated life, but also to cope and not to be burnt out, etc., etc.? And I guess that might be more for you, Helen. I don't know.
Yeah, I guess the team's very small, so there's 3 practitioners. Maz acts as the team manager and the clinical lead. So the team is tiny. The caseload is roughly about 30 at any one time. So it's a very intensive caseload with a small group of people. So absolutely, we've been thinking about having bringing in some psychology support for reflective practice to make sure the team are supported that way. And yeah, we're just looking at different ideas. Can I just go back to the neighbourhood thing? Because I think what's really important and what's really been successful is the team going out and talking to people in the neighbourhoods about the inequalities and break down those barriers. And we've got some good examples of that. So the service users that are under don't have to queue up for the sexual health services in Greenwich, because we're very close to sexual health to make sure that people are not queuing up unnecessarily to wait. So I think it's about talking and being visible, and certainly the team have done a lot of that in the last. That's what's really important.
So maybe that's the role of an integrator, to talk and talk. Iffy.
Thank you, Chair. And Mazin and Helen, just to say thank you very much for what you do. I think this is a really good example of what I consider to be outstanding work, but how, given what I said earlier, how one ensures that it's publicized, because it really does address a lot of the things that we see as priorities in Oxleas. And I'm sure we'll come back and talk to you some more as we develop our neighborhoods, because what you're doing is you have a group of people that are clearly defined and for whom you're providing everything to get them to a better position. And that's what our integrated neighborhood teams intend to do when we finally get there. And I just want to embarrass Helen, because this month she retires and leaves Oxleas. I wasn't going to say that, but you said it. And just to thank her for all her contributions in Oxleas, and it couldn't be a better way to leave than to present to the board the work that you've done with this team and many other teams, of course. Thank you.
Thank you very much. Thank you. I've had 26 happy years in Oxleas, at least. So thank you.
Well, thank you, Helen. And clearly, if we could bottle you, we would, I think. I mean, that is absolutely brilliant. Thank you both, Helen and Maz, for that. And if you wish to stay, do, but don't feel the need to, of course. But thank you very much. Really, I think you've seen from the response how that's been taken. Thank you. So I think that's a really good basis for our meeting, a really good foundation for what we are going forward on. So I'll ask Giffy now to take us into the board assurance framework update, which is just an update.
Thank you, Chair. And as the Chair has said, it's just an update, just a couple of pages in the pack. You see there are 10 items on our board assurance framework, 4 significant, 3 high, 2 moderate, 1 low. I'm sure that the Business and Infrastructure Committee will be looking at the will be looking at the revenue and capital plan delivery, which is an annual risk. And hopefully by the time we meet again, we'll have the new risk description and also the risk level. But other than that, I didn't have any more to say. We did go through this in great detail at our last board meeting. Thank you, Chair.
Thank you. Questions or comments, Az?
So it was just to say we would fully be expecting to change that, and I'm expecting the rating to come out as moderate once we've done that assessment for in-year delivery.
Thank you. Okay, good. Thank you. We'll move on to Chair's report, and just to warn you, we do have to make a decision in the Chair's report, which is unusual, and I'll ask Suzanne to step out if I could for that one, and then have back in again. Thank you. So I'll go through the bulk of my report in a moment. But one of the things that it's the board's decision is that I'm proposing that Suzanne Shea replaces Jo as Senior Independent Director from the 1st of May. The NED Nominations Committee, which of course is a governor's committee, though chaired normally by me, but in this case not me because of the role of the SID in overseeing myself and doing the annual appraisal, was supportive. They met on the 24th of April. There's an outline of the role attached. I personally think Suzanne would make an excellent senior independent director, given her experience on the board and everything else. But I will let other people say things they will. Any comments that anyone will have at this stage? Yes, Damien, and then Rachel.
Very happy to support the recommendation. As a new Ned, I don't know her that well, but I'm sure she'll make an excellent SID. Is there a formal job description for that role? And should there be one? The logic for it is being SID in good times is, dare I say, an easy job when all goes well. It's a terribly difficult job when things are tough on the board, very stressful, very difficult. And I think having a proper job description that addresses the rights of the SID in terms of what the SID can and should do goes a long way to make life easier when there's conflict on the board or, God forbid, an issue with the chair. So I would strongly recommend something in writing that can be referred to in case of a crisis, just in case.
I mean, we have a role description, but you're suggesting something more than the role description. Sally? No, sorry.
I think most things are covered within our constitution. So I don't know that we necessarily need extra paperwork, but we can just double check.
So we'll double check that. Rachel?
Thanks. So wholly support Suzanne being new SID. I've worked closely with her on a number of sensitive issues, and I know that she will do this extremely well. Just wanted to note one point, which was that it had previously been suggested by our outgoing SID that it was important for that person to have strong links with the People Committee. And I think we can easily make that happen without her being a member, just by making sure that there are regular updates. And I'll just arrange, if Suzanne is appointed, I'll just arrange some regular meetings to keep her abreast of developments.
Thank you. Any other comments? Abby?
Thanks, Andrew. I do support the kind of nomination. I just wanted a point of clarification because the SID would be the non-executive director that is named within the Maintaining High Professional. I can see that it's separated out. I was just asking whether that's because of a conflict of interest on Suzanne's part from the GMC. Okay.
So that is partly because of a conflict of interest, and also partly because, and we'll cover it in a moment, Martin also has very good credentials, I believe, for doing that particular role. And constitutionally, and actually in guidelines, those two things don't need to be taken. We have chosen to take them together in the past, but we don't need to take them together going forward. Okay. Can I assume by people's nods that we accept Suzanne as SID?
Yes.
Lovely, thank you. Could you, Ian? Thank you. Let her back in. Yeah, I'm going to put this back on again. It's always embarrassing when they've gone too far away, isn't it? I'll just say congratulations back to your chair. Thank you. Okay. And just to say, one of the things that we are going to do, Suzanne, is check that we have enough written about what the role of the SID is, and that's one of the things in the combination between the role and the Constitution. So that there may be a bit that's something that we will share with you afterwards. Okay, so my executive summary. First of all, as I said in the conflicts of interest, declaration of new conflict of interest, as of today, I've taken on the role of the Health Innovation Network for South London, which is the body charged with delivering, helping deliver health across the two ICBs of South London. obviously I kept everybody abreast, including the previous SID, abreast of this development. I think it's a really helpful role. I've already entered into discussions with King's Health Partners and with with various people in both ICBs about how we can actually join together all of the innovation work that's going on across South London. Because I think my perspective on it is that at the moment, people like the HIN and KHP, King's Health Partners, and there's an equivalent one for George's and City University as well, though probably less well developed. A lot of them are doing goodly work, and we heard a bit about the HIN report here for that work on the rough sleepers. But that there's actually very little visibility about what they do, and there isn't always clarity about what they each do and trying to get them together. And so one of the things that I want to do in that role is it's one of the two things I really want to do in that role, which I've made clear, is first of all to be able to tell the story of what these bodies do in a joined up manner so that they can help people in a joined up manner, and that you don't have to go and knock on 3 doors to find out which door is the right door to help you on. But also to see how they can align to the strategies of the providers and the ICBs and the other organisations that they are supporting. Because again, Abby and I have had discussions about the HIN, and it's, the HIN does goodly work for us, but it's not quite clear who's commissioned that goodly work always. It's sort of slightly random. And I'm very pleased that they help with the rough sleepers, but why have they helped with that and not with something else? That might well be the right thing. But there's no sense of being strategic about how these innovations are helped. So that's going to be one of my ambitions. The other thing is we've already welcomed Martin onto the board, and we said farewell to Jo. I think a lot of us will be in mourning for Jo for quite a while, but she went with our good wishes, and I know if he's got plans for using her services in other ways. Already talked about the appointment about the SID, and I'm very pleased that Suzanne's agreed to take that on. Jim will be taking on the chairing role of the BIC, and Martin, thank you, is going straight into the hot seat by taking over, as we discussed with Abby, the maintaining high professional standards of it. And I also formally report, and it's now been, the summary is now being given to Sally, that I have undertaken a series of appraisals with all the non-executive board members and with the chief executive, and that process is therefore now complete from that point of view. In terms of wider things, I think that there's several reflections that I've got at the moment. I'm not going to talk about the various changes that are going on in the NHS and the NHS structures. If he's going to talk a bit more about that, I think, in his report, and I think they've probably been fairly well touted. I think my reflection on it, and having listened to talks by Jim, which both Jim McKay, which both Ify and I have been at, and other talks, is that actually there is one's got to be careful to be Pollyannish and look for positive in any situation. But I think one of the things that is going to be happening as the ICBs are shrunk and the NHS England moves in a smaller form into DHSC, is that much more is going to be given to the providers. I think we are going to be masters and mistresses of our own fate far more. And actually, we're going to not, and I don't think this has been the Oxleas ways anyhow, but we can't sit here and look for solutions to come down from above and then to enact them. We're going to have to find the solutions ourselves and propose the solutions. There's just not going to be the bandwidth anywhere else to do it. I actually think that's welcome. I think that that's something that we can do. I think there are also some, there are clearly some risks as the ICBs and other areas are shrunk, that it's not yet clear, at least to me, where they're going to concentrate on and where they're going to add value. And there's a danger, of course, that they end up doing everything poorly rather than a few things well. And I think that's the thing that we're going to have to work with them and help them out. I also think that my reflection is as well that that's going to make working in partnership between providers also ever more important. I mean, I think for us, South London Partnerships on Mental Health, the Cavendish Square Group, on all of the other ones. And I think we would all recognise that these are strong partnerships we have through those groups, but they are not always firing on all cylinders. And they're not, and I think that the fact that those are not firing on all cylinders all the time is a major problem, because I think those are going to be the engines of changes. If we want to, sticking to mental health for the sake of argument for the moment, if we want to change mental health across South London, then we need to get South London Partnership firing on all cylinders. And that's a difficult task. You know, we're trying to do that and it's not working particularly well at the moment in every place. In some places it's working really, really well, but it's not working across all of them. And I think the same is true as well with physical community care, that if you look across South London, we've got many models of how neighbourhood teams and how communities should be. And again, I think we're doing a really good job, especially perhaps in Bexley, we're ahead. Other places are catching up, but you know, we've got a very strong vision of what we want to do in that area. But we need to be able to talk to our partners. And one of the things that you know, I think Ivy and I have also been noticing is that this means that other people want to get into this patch who weren't in this patch before. So, for example, Kings are not wanting to run community care. They absolutely do not want to run community care, but they're beginning to say that they want to understand what the levers are so that they can influence it. And I think that's quite right, because community care has got to involve the acutes, partly because it impacts on the acute services, and partly also, to use Andrew Bland's term, if the ologists are going to get out of the hospitals and into the community, they're where they're going to come from. And so somehow we've got to find a way of bringing on board people like Kings, who previously, frankly, I don't think have been that interested in community care, and bringing them on board without them necessarily wanting to or indeed running the services. And I think that's just going to take a very subtle form of relationship for us to do. And it's one that we're going to have to think through. So again, that's a little bit, well, I don't think that's 30,000 feet, that's probably about 60,000 feet. But that's, I guess, where I'm feeling at the moment our main challenges are in this area. Any questions or comments, Rachel?
Thanks. So you mentioned about the ICBs and their shape and what that was going to look like. And I've expressed previously my worry about there being no design to how this is done. So it's done in a fragmented ICB by ICB basis. I was relieved to hear yesterday that there is going to be a target operating model for ICBs, which hopefully will drive some level of consistency. But then I was then disappointed to hear that it's been promised for a long time and just doesn't seem to be coming. So there's kind of either give with one hand and take away with the other. Really welcome the opportunity for us to work more closely with HIN, particularly because of our focus on innovation in the strategy, which I think we're really starting to build. And also because I think we're at the stage now with the work on building fairer Oxleas services that Ian leads, where we've got some really chunky projects now, I think, where we are really going to need to think of all of the levers that we might have to try and address some of those really difficult health inequalities. So it just feels like it's a really good moment for that closer partnership.
Thank you, Martin.
Thanks. And it's really a reflection on the last item, Chair, if that's all right. And you said in all the changes, likely we need to be masters of our own destiny. And I absolutely understand that. I think there's two reflections to build on that. So one is we also need to be in control of our own accountability. We can be passive and sit back and wait for the layers above us to hold us to account. And yet, increasingly, we will have to be the active partner in the accountability of that, and that puts extra responsibility on this board. So it's a reflection. That goes back to your comments right at the before the official start of the meeting around the need to see how do we deliver good care, how do we measure what we do, and how as a board do we understand that. And Suzanne, you asked that question of the homelessness team, and I think it's really important we understand that about all of our services. The second thing is about our partners, and we can see them as oh, Johnny come lately threats that we're worried about these big people wanting to get in on our business. And actually, we're the drivers of the model of care for our communities in integrated ways, integrated neighbourhood teams. We have expectations on our partners to help deliver those better, particularly the secondary care sector. And I think we need to start to be, I'm sure we are already, but we need to be really clear about our expectations on them to help us deliver for our patients.
Thank you. And I totally agree with that one. And I think that, there is a problem at the moment, there is an issue at the moment that so much of the NHS focus is on enabling things in acutes in a very narrow sense to run well. And therefore that slightly puts the onus, sometimes the dialogue therefore comes, how can we help the acutes do their job better by whatever it might be? And I think very much we've got to change that dialogue into what are we going to do to serve the people that we are here to serve as a team. And that, you're right, I think we need to be more demanding of our partners, and also be willing to cede power to some extent as well. It's going to be a much more subtle relationship. Anisa.
Just a comment, I agree with that, but I think we have to be careful not to forget primary care in that. We have a sort of a tendency to look up to the acutes and changing our relationship with them, but the relationship with primary care is just as important, and we shouldn't sort of make the same mistake that we criticise.
Good point, accept that. Sophie.
Yeah, thank you. And I think it is something about that whole narrative going back to prevention as well, not looking at acutes in silos, but looking at how in communities you can prevent people from needing to access the acutes. So keeping that narrative front and centre all the time, I think, is really, really important.
Thank you. Suzanne.
I haven't seen the trails of the proposed target operating model for the ICBs. But I think one of the big disappointments with the ICBs is that they haven't really helped us to understand much about our future population needs. And I was really struck receiving a presentation from Hospice UK recently on the huge rise in the number of people who are going to need care right at the end of their life. And I'm just wondering how far we as a trust are looking at the next 10 years, because that's really going to impact the services that we provide, both physical and mental health care for people who are coming towards the end of their life.
Thank you. And I think one of the things I'm hoping that will come out of Alex's board review is some look at actually, are we considering enough about the needs of the population that we serve in that sense? And I think that some of that is also, where do we get the data from? And if, again, I look at South London, population health has many homes, and actually, I'm not sure that's the right solution. We actually, we can't have a population health team here doing it all. Where do we get that information from? And there tends to be a lot of sort of kitchen table type of population health, and we need to get better at it. And so that's one of the things I want to talk to KHP and the HIN about, and indeed GSTT, who have quite a strong element in that, and King's College, the university. I think that's a fair point. Aswa.
So I think there was a piece that we're currently going through with South London Partnership as well. We were looking to reduce that central team. I think some of this sits with what exactly is going to be the content of the strategic commissioning that ICBs will be doing, because for me, they can't do that without actually fully understanding the population health. So I do think there's a conversation that we need to have with the ICB about setting some of that direction of travel that we can definitely then take on and then further analyse and process through our services. But I do think there has to be a central look across the ICB of fully understanding that population health. And I think they've got the resources there, but there's simply not that dissemination of the information with ease that allows us to then really take that on board without replicating.
Thank you, very helpful. Iffy.
Come back on. Sorry. Yeah, I was trying my best not to comment because much of what's being raised I have in my report. But I think it's important to just make the point that the ICB, the model ICB paper, will probably come out tomorrow. Should have been out today, but wasn't, we're told, because of the elections, which obviously don't affect London, but nevertheless, that's the way these things run. And there's a meeting tomorrow morning of all the ICB board members to discuss changes in Southeast London ICB. At a meeting I went to a couple of days ago, the figure that they've been given by which to reduce their overheads is £18.76p. So they need to work it out. I hear that if that's done across the entire country, there'll be a saving of £900 million. If we successfully apply that in Southeast London, we will save £21 million. So people are looking at me surprised. This is per head. So 50% was the first thing that Jim Mackey started off with. But for us, it's down to something between 30 and 40%. So having set that figure, it enables people to take account of the size of the population, etc. And people may have heard that there are suggestions that ICB numbers would drop. That's possible. Nothing has been confirmed because some of them, once they've taken out the overheads, may be too small to function. And so there's a suggestion some of them may merge, probably down from 42 to 30. Not sure yet. Nothing has been announced, but I think there are discussions going on. And the final thing to just say about London is that we'll maintain our 5 ICBs, is what's been said. Yeah.
Yeah, thank you. I just wanted to come in on the population health conversation because I have a slightly different perspective on what information we have about our local populations. And I think sometimes it's quite easy for perfection to be the enemy of the good. As a member of all 3 of the local care partnerships, there is good information around the population of each of the local boroughs, and that is very much driving the work of the partnership of which we are a member of. And there are active conversations about how we try to kind of lever something from that information and kind of drive intelligence and forecasting. So it could be better, but there is that information there. Yeah.
Okay, we'll move on to Iffy's report, having hopefully not taken too much out of it. And then I propose after this report and this item, we have a coffee break and a leg stretch. Thank you.
Thank you, Chair. No, you haven't. So I'm going to, as always, assume that board members have had a chance to read my report. I'll highlight a few items and then happily take questions. So you'll recall the last time we were here as a board at our strategic meeting, we discussed the changes in the NHS, much of which has been mentioned again this morning. And I noted then that Sir Jim Mackey has been appointed as the transitional CEO for 2 years, with the responsibility of bringing together NHSC and DHSC. We were at a meeting on Tuesday of all chief execs, including ICB chief execs, where he confirmed that he has now successfully completed the appointment of his transitional team to then begin to do the work that needs to be done. I think he recognizes that quite a lot has been done in a short period of time, and I couldn't help but conclude, this is my personal view, that this is all about grip and control. As I said when we talked the last time, that it seemed to me that the thing that really forced this agenda of coming together at the time that we had it was the fact that there was a potential £6.6 billion gap for 25-26, and so that was accelerated. So there are multiple strands of work that he talked about in terms of the next steps, some of which we've touched on. He was quite delighted, and I think we all know that the planning has planning round is now complete. 30th of April was the final meeting. I think the figures we saw 2 days ago is that from 6.6 billion that was first mentioned about February time, we're now down to 105 million. That's the deficit. And that's been reached with a 2.2 billion support to various systems. Just to say that one of the systems that's still not planning to have a balanced position is in London. And the discussion on Tuesday was that they were still working on it. So it may be that by this morning, it's gone from 105 down to something else. I think that the team that Jim now has is very keen to drive quite a number of programs. We've touched already on the model ICB, and it's said that one of the things that they're going to be very keen to put in there is what their role will be as a strategic commissioner of services. And whilst there was a great deal of talk about them no longer being responsible for overseeing finances of organizations such as that, many were keen to say that it's going to be difficult to imagine how you commission something and not want to say, am I getting value for money? And so you are going to have to engage people in those discussions. And the suggestion is also that NHS England regional teams, we took over some of those responsibilities. We touched on the NHS performance assessment framework. I think that that's really coming to life. There is a suggestion that we should, by July or so, have the first cut of what it will look like. When we talked at the last strategic board, we showed some indicators. There were 87 indicators, probably going to be down to 30 based on the planning guidance priorities. But what will be really clear when this is published is the absence of data that relates to trusts such as ours, mental health and community health. And that's fundamentally because there isn't a great deal of data for us to demonstrate the work we do. And I think that again underpins why we have to do a lot of work to show. I think that also speaks to your point I made earlier about how do you show the great work that we do in services such as ours. Something that the finance people in the room chuckled when it was mentioned is to move away. There's a real desire to move away from the annual planning cycles to 3 to 5 year planning cycles. So 3 years of revenue allocation, 4 years of capital allocation, with a new financial framework. And I think that that's the bit where in Southeast London, we need to look very carefully because there's been a great deal of talk about fair shares allocation, which we fear could disadvantage us by up to £175 million in Southeast London. And if that were to happen, then our plans to achieve the balance that we've agreed to for 25-26 will be blown out of the waters. So the risk, there's still a great deal of risk in the 105 million. And the other things that need to come in, costing, productivity, and this point that you made, Martin, about provider regime and accountability. I think many people were being nostalgic, going back to the good old monitor days and TDA, where foundation trusts were real masters of their own destiny. You took responsibility for your work, you made sure that you provided great services, and the finances entirely your problem. And I think that that's one of those things that we must do in Oxleas, because we know that when we deliver great services and in control of our money, we can get on and spend less time being engaged in regional meetings, etc. We also had something about the 10-year health plan, which you see is absent from my report. Last week I was in Leeds, and Sally Warren, who is the Director General, talked to a number of us, and I chaired a panel talking about the impact it might have on mental health. And although I'm told, she said it last week, and Tom Kibasi said the same thing on Tuesday, that they have a report that's already written, but no one will share the report with us. I can only guess from what Tom said that the real challenge is you've had all of these people feed into this report, loads and loads of ideas, particularly for members of the public. And then you have the Secretary of State who has said, this has to be done and this is where we've got to go. And the anxieties right now as they begin to wrap it all up is, can we deliver this? And is there the money to deliver it? And isn't there a great deal of distraction, in the system, that this will just be one more thing? And I think that that's something that they're going to try, and we are going to part of course. We're all going to try our absolute best to get behind. Delivery date or the date that it's going to be available is thought to be before the Parliament goes for its summer recess. So, not sure when that is. July, maybe. Who knows? Or even August. So we'll see. So, and we already know, broadly speaking, what the 10-year health plan will be about. It will be about the 3 shifts, and it's going to really, really emphasize neighborhood teams, which will be central to the work we do. I think one of the other things that is obvious, it was in the Darcy report, and Tom mentioned it again on Tuesday, is that when you look at the growth in terms of money that's come into the NHS, 75% has gone to acutes, 20% to primary care, maybe 30% to a trust such as ours. And of course, the acutes are now solid with patients. They can't manage, costing a lot more. And how do we then change that without any new money? That's going to be a real challenge. And that plan has to be able to plot a path through that. So in some ways, I'm glad I was just in a group that talked about people, and the more clever people are now trying to figure out how to land a plan and make it work. So that's all I wanted to say about the way NHS is organized, and there's a lot in there, of course. I think I have also touched on the performance assessment framework. I want to just mention the Supreme Court ruling on the interpretation of the Equality Act, that we're waiting for guidance, but Ian, as the exec lead for our LGBTQ group in Oxleas, met with them last week, and they're keen for us to put something out to our staff. And I'm meeting with their chair, or I have actually a meeting with their chair tomorrow, and we'll draft something just to reassure staff about our commitment to equality and diversity in Oxleas. But for the broader implications, we're going to have to wait for NHS England guidance whenever that's published. Just to draw attention to the fact that specialized services have now been transferred to local ICSEs, that will affect us with respect to South London partnership programs that we run. We cannot immediately see any key issues of concern, but of course time will tell. And in some ways, given the reduction in ICS headcount, not quite sure how that's going to land, but I'll keep you informed. The other thing I want to mention, which is in my report, is our response to the recommendation in the independent mental health homicide report into the treatment of Valdo Colocane. As board members will recall, Mr. Colocane was a patient in the early intervention in psychosis team of Nottinghamshire Healthcare NHS Foundation Trust. He was discharged to his GP because he wasn't engaging with them. Tragically, in June 2023, he killed 3 people. The CQC investigated or reviewed the services of the trust, published their report in August 2024, and we brought our response to that with our action plan to the board in September of 2024. Since then, there has been another independent homicide review conducted and published in February of this year. And on the back of that publication, NHS England Road to All Trust, requiring us to review those publications, review our action plan based on the CKI's recommendations, and to present something to the public board. You see in the papers that I've set out how we're updating our action plan, and our proposal as an exec is to bring a more detailed presentation to our July public board meeting, where we can talk about the work that we've been doing and give a sense of where we're headed. Two more things before I end. One is our NHS staff survey. I said to Alex as he walked in, I said, it's a good thing that it's you who is here, because his trust is the only trust that beat us to the top place in the country of trust like Oxleas. But we're delighted that we're ahead of every trust in London. And it was good to hear in my absence last week of the news that was made of this at the London CEO's meeting. But that's not to say that we don't have areas to work on. As you see in my report, flexible working, discrimination on the basis of ethnicity, and a number of other aspects of our staff survey require further work. And I'm confident that our People Committee will help us drive that improvement. Many have said this morning, Chair, about the Living Within Our Means program, and I'm delighted that many colleagues commented on that and saw that as their commitment for the coming year, which means I may be able to sleep better, which has been a problem more recently. But I think we're fully committed to that, because if we don't, for the reasons I've already articulated, we will struggle. And I certainly don't want NHS England, London region to spend time on Oxleas. I want them to think and talk about us in terms of what more we can bring to London and beyond. And that's all I wanted to talk about, Jeff. Thank you.
Thank you, Iffy. Questions or comments? We're going to have to do it backwards and forwards here. Suzanne, is it working? Yeah. So.
I've got a comment and a question. So it was interesting to hear about the response to the Supreme Court's decision. And I think it's been really difficult that the Supreme Court emphasised that this wasn't about one side winning and another side losing. And I was just wondering how far, clearly we're going to engage with our LGBTQ network. Are we also going to engage with Women's Network? Because I think that the BBC, for example, has come in for criticism for only engaging with the LGBTQ network. The other thing I'd wanted to ask about, and I was really pleased to see the announcement of the Women's Health Hub. And then when I looked at what they were going to do around women's health, it's really a reproductive health hub, isn't it? And I was really struck that the number one cause of death for women is heart disease. So what is the ICB doing more broadly about that? And are we going to be involved, given that it's very much a preventative piece of work?
So on your first point about engaging the Women's Network, I'll say yes. And I looked to Azra. She didn't look in my direction. So certainly before I put anything out, I think we need to be absolutely clear that we've covered everything. I have no idea whether NHS England, if they issue any guidance, I don't have a sense of how far-reaching that will be, but I hope that they'll be thinking in the same way. I think the hub is an interesting one. I take your point, but sometimes got to be careful how I say this. Sometimes these things are just done and said to be a news flash. They don't really think in great detail. But that said, I think that most ICBs, particularly through the local partnerships, are doing stuff, for heart disease, making sure that every contact counts, making sure that people's blood pressure, etc., are checked, for example, and also ECGs. I think a few years ago, we were talking about the wand in Bromley, whether you could do simple ECG checks on everybody, to just pick up those who perhaps have fibrillation, who might end up with strokes, etc. So I know that there are all of those, but your point, I'm sure, is that it's not coordinated in a way where if women are going to come to a women's hub, you get everything done. We may well advance to that point, but I'm not aware that there's any plan as I speak for us to do that.
And I think if I might comment on that one, that's an interesting one, isn't it? Because actually you don't need a lot of high cardiology expertise to do an AF test. That's actually something that we should be empowering people to do locally. And so it's not about bringing the cardiologist in, it's about bringing some Fitbits or things like that in. But let's comment on that as well.
So I was just going to comment on both of those. I'll touch base with the lead of the Women's Network just to check, but my experience of when we've met together, there's quite a large element of intersectionality across a number of our networks. So I think there will already have been some discussion, and I'm expecting it to be fairly supportive of some of our trans members of staff in terms of where that lies. But I recognise the point that you're raising, because there is definitely two sides to that coin. The second one was in terms of the Women's Hub that has been set up, just drawing an experience that we've had from the menopause support group, that was actually very widely welcomed by the Women's Network, because we've had, as well as for our population and some of the queries that they've had, that's a really underserved element of the service that is being provided, and you have differential services out there depending on how the primary care interface works. So I think there was a feeling that drawing that together for Bexley and Greenwich into a Women's Hub would really allow us to reach out both for our members of staff that live within those areas, but for our population wider. And then I think from there we could signpost into some of those other areas, because it's concerns, but it allows people to then have a route area that they would be able to go to, a known place that they would be able to go to. And I think from there, some of those discussions will then raise about some of those other issues. But at the moment, it is very much, as you'd said, centred around that element.
Thank you. Sophie.
Yeah, just to pick up on the hub point, I think it's really important that we think about these opportunities for greater access. So as was said, really, it's set up for one thing, but actually if people feel comfortable there and we know people are meeting there, it's then a springboard for another thing. So again, it's looking where we deliver services as well as how we deliver them. I think that ties together quite nicely.
Thanks. I think my point is to add to it, it's where we, but also who delivers the services, and actually it doesn't need to be specialists necessarily doing everything. It needs to be other things. Suzanne, did I see your hand up?
Yeah, I just wanted to sort of come back on the Women's Hub, because it goes to the point that we need to take charge of our own destiny. And if we think that that Women's Hub is a great place to draw women into broader considerations around their health, then we ought to be really pressing that. And there's the opportunity to push further than perhaps the commissioned service without it costing us huge sums of money. Maybe about signposting, about making people aware, about bringing in some of the VCSE organisations that can advise.
A good, important point, and I think that's, yeah, we need to always get that into our mind, and we might get something that's funded for one reason, but we can cheaply add something onto it at minimal cost. Any other comments or questions for Iffy? In that case, we will break for a coffee. I'm going to suggest we come back at 10 minutes to, so we have about 12 minutes for coffee. And for people online, we will rejoin in about 12 minutes, I think, for my one. So welcome again to people who are listening in. We're now going to go to item 8, the operational report. Ian.
Thank you, Chair. So as usual, there is a detailed report from each of the directorates, which hopefully colleagues have seen in the reading room. And then there's a summary of what is in those reports included on the front sheet. So I wasn't going to go through those in detail, but as always, happy to take any questions or comments. And then similarly, you have the summary of the performance metrics and some narrative about the exceptions, all of which have been discussed at Quality Committee. So over and above that, I've highlighted 3 things. The first, I just wanted to draw attention, and it was interesting the conversation that we had earlier about working as a system. I just wanted to highlight Super March. So 2025 isn't the first year that we've had Super March, it's actually the second. But it has felt significantly different this year. And although we didn't meet quite, or LGT didn't quite meet the target that was set for them around the compliance against the 4-hour target in ED, they came close. But really, it's what lay beneath that. And I think colleagues have talked before about the, in fact, it was Helen who mentioned about the need to talk. I think what's created the difference this year is that it's felt very relational, and there has been some leadership changes within LGT, which has allowed a much more openness, I think, to the system, and given the system an ability to look in, as well as helping acute colleagues to lift their view and look at the potential of what's happening out in the community. So it's felt tonally very different, and because of that, we have achieved a lot together between ourselves, the 2 local authorities, and LGT. And as it says in the report, we've highlighted a number of areas which we will continue to take forward, and this has really been underpinned by a review funded by the Better Care Fund of the leadership across Bexley and Greenwich, which again has been a really helpful enabler to that. The second thing, mention's already been made about integrated neighbourhood teams. So we are moving towards implementation, albeit at a slightly different pace dependent on the individual borough. There is a shared South East London framework. And again, as already been mentioned, there is discussion at the moment about the role of the integrator and what that might look like for each of the 3 boroughs. And that backdrop of change within the ICB that Iffy mentioned earlier, and the reality of a kind of shrinking of the ICB presence, I think is really starting to create a conversation around what their residual role might be and the importance of retaining that kind of enabling function that they deliver at the moment, but also the opportunity that it sets up for providers like us to step into that space. And then the last area, which has been mentioned several times, living within our means. That programme has now been initiated. We had the first meeting last week. There is in the report and in the reading room an outline of the suggested governance around this programme, and that has been written into the revised terms of reference for the Business and Infrastructure Committee. The 3 cross-directorate programmes that I mentioned at the strategic board presentation are either in the process of being established and the initial meetings happening, or being realigned in the case of the bed recovery programme to ensure that it is very much linked into delivering on the milestones needed to deliver the programme. And meetings are taking place currently and over the next few weeks with both service directorates and conversations with corporate teams to support the delivery of the kind of drafting of directorate level schemes and team schemes by the end of May. And that is all I was going to say. Happy to take questions.
Thank you, Ian. Effie.
Ian, thank you so much for your report, and thank you especially for highlighting Supermatch, which, if it wasn't labor intensive, I'll say, why can't we have this every week, right? But I'm really hopeful that the plans you've set out there for Oxleas to take forward will help us. And I just thought I ought to mention that as the chair of the Community Provider Network for Southeast London, we've been thinking about how we can do this more broadly across Southeast London. And so we've just agreed that we'll have a strategic leadership group that will include acute providers. Because I feel quite strongly, not everyone does, but I feel strongly that if we're going to succeed at making this left shift, we need to respond to the deluge of patients knocking at the doors of acute providers. And yes, sometimes you'll catch me saying, well, our success is judged by what the acute say of us. But in reality, they're the ones who are facing the challenge. And so I really want them to be in the room, to be part of this executive group, as well as primary care. So we're going to invite the ICB primary care representative on the board, where every 3 months we're going to be thinking about what we can do differently or what more we can do to be able to move things forward, particularly as we get into neighborhoods. Because the decision, as I'm sure colleagues have heard, forgive me for rehearsing this, is that we're going to take those patients who are frail, who pitch up in hospitals. We're going to have to wrap our arms around them in the community. We're then going to look at those who have 3 or more long-term conditions, and then in time, we'll look at children. And I'm very keen for us to identify those who repeatedly go to acutes by name, to then see what plans we'll put in place. So it's really good to hear Ian showcase this. And if you also look at the acute community provider report, it talks some more about Better Care Fund and all of that. So that's great. Thank you.
Martin.
A comment, if you will, about the integrated neighbourhood teams, and just repeating my potential conflict of interest with PPL, who are informing the South East London process. First part of the meeting, we mentioned population health management, consistent community health services, great GP or primary care services, multidisciplinary teams. These are all playing on our roles. That they are the core components of government policy on integrated neighbourhood teams. And it's a question, I think, is have we had, and if not, could we have in one of our strategy discussions about our approach overall to neighbourhood teams, rather than just letting 1,000 flowers bloom. Now, maybe you've already had that, and that's great. I just need to understand that. But if not, it seems like it's an important time to have that discussion.
Ian, do you want to comment on that?
Yeah, I do think it's a good idea. I think in terms of visibility at the board, there was a presentation just to kind of bring people up to speed about the concept. So that was a few months ago. So I think the pace of change is quite rapid. So very happy to kind of consider how we do that. Yeah.
So I think that would be good. This is one that we're going to have to keep our eye on, because it is going to be a central plank of the 10-year plan fairly evidently. And I also think that while we are beginning to, I think in South East London to get alignment, there still are some quite different models across South East London of how it's happening, and that's both fine and dangerous at the same time. And we've just got to make sure we stay on the fine side of that line. Any other questions for Suzanne? Sorry.
Thank you. It was a question about Supermarch and one of the outcomes. And we've said that we've committed to considering joint roles, especially at leadership level. Can you give us a little bit more information about that?
Yes, absolutely. So the first one that's under consideration at the moment is the creation of a transfer of care hub, which I know the NHS is very keen on hubs, but this is a kind of hub that's been around for quite some time. We've tried to do this before in the kind of Greenwich and Bexley system, but it's essentially somewhere which could be physical actually in the hospital, but more importantly, it brings together the different organisations and brings that to bear on discharge. And so it needs leading. And so what we've undertaken to do is to create a role that is kind of jointly invested in and works for the system. So that's the kind of first one. Myself and my counterpart at LGT, Miranda Jenkins, together with Sarah Birchall and somebody called Joe Sutcliffe, who's the deputy coup, we're also just exploring how we try and help clinicians and managers from both acute and the community to understand each other's roles and points of views. And so I think that the idea is that through that conversation and with specific pathways, we would then start to consider whether there's an opportunity to look at roles which help manage that interface a little bit more, like TOC does, I suppose. Yeah. So it's very early days, Suzanne, but yeah.
So it's just a comment on that, and I think when I visited the single point of access, the thing that really struck me was what a big chasm there is for patients leaving hospital and getting care at home. And I think the more that we can contribute to ensuring that that's a smooth journey, and recognising that it's not just about the admin, but it's also about counselling people who are scared. Have had a hard health problem and maybe feeling very nervous about going home.
Thank you. Ian, can I ask about the, under the adult community physical health, the review of the Bexley external district nurses? Because you talk about challenging concluding, and it looks to me that if we're getting non-recurrent funding of £1.4 million, I assume that that's approximately the gap that we would see. What can you just give us a bit more flavour of what's going on there?
So the report, which is the culmination of the review, landed this week. I received it yesterday, so I haven't had a chance to look at it in detail. In some ways, there aren't any surprises in the report. It very much mirrors the internal piece of work we did probably about a year or so ago. And essentially what it's saying is that there are activities undertaken by the team that possibly could be undertaken in other bits of the system. So there are things we can do to try and reduce the volume of activity going through, look at the criteria, but we will still have a funding gap. The 1.4 million non-recurrent funding does not close the gap totally. Asraf, you might have to help me out here, but I think the gap is over 2 million.
In relation to,
Actually, district nursing.
It was 2.5 million last year is what we actually received as funding. We're up about 1.4 this year, so there's quite a major difference.
So, and it is because of that, linking this back to living within our means, we are trying to identify a number of services where the funding we're receiving is not keeping track of the demand. And this is one of those. And then that will set up a series of potentially quite difficult conversations with the rest of the system about how we manage that. Having said that, Bexley are hopeful that that non-recurrent funding that they have provided this year may be extended further, but I think it's too difficult to kind of be kind of certain about that.
Understood. I guess we've got to be careful not to simply just transfer costs elsewhere in the system, especially if we increase the cost by doing. Abby.
Thanks very much, Andrew and Ian. Ian, in terms of district nursing, I know we talk about the kind of demand, but I think, are we considering anything we can do in terms of transformation within the service and the model that we provide? I know we will need to have discussions with our system partners, but as we've mentioned today, what will district nursing look like in 10 years' time? in 5 years' time, in 10 years' time, and what should people be expecting? Because now they're expecting a lot.
Yes, and you'll have seen within the report, in the reading room, the work that's going on in Greenwich in thinking about kind of technology to kind of assist in the delivery of care. And I think if you talk to district nurses, and colleagues know this, that they're often meeting need that could be met by the kind of patient's system, by the patient themselves, and it's about that creating that confidence to do so. So I think there is transformation linked to technology. There is a system conversation around where does the work flow, and there is something about what it is that district nursing is uniquely placed to do. If we cover all of that off, let's see whether that reduces the gap further. But in terms of kind of mental health, it's analogous to community mental health. It's lots of things, lots of activity flows through that, and it's about how we have conversations around what do we want this, precious resource to do. I should have added that there are always ongoing conversations around is there more that we can ask district nurses to do? And we were having that conversation this week. I think if you asked the service, they would say that they're very competitive in terms of the number of contacts they provide a day. And there may be more that could be looked at, again, using technology to reduce activity that is not patient facing. But I think there's not much wiggle room there.
Yeah, really good question, Abby, and Ian, I agree with you completely, and I hope that when we have the chance to dive deep into the review that's just been completed, that it will give us a sense of how we compare to other places. Some of the things that one hears is about the absence of practice nurses, and therefore things fall on district nurses. The fact that some patients who are not housebound are referred to district nursing. There are lots and lots of things that one hears. I touched earlier on the 10-year plan, and one of the questions that came up last week at the event I said I was chairing a discussion group was the degree to which we as citizens should be encouraged to take responsibility, and the response that came back was that politically it's a bit of a hot potato on the back of the most recent survey result about people's feelings about the NHS, that you cannot go back to people who are saying this is the worst. If you compare from however long ago the satisfaction reviews started, people are saying the NHS is really bad, issues with access. You then go back to them and say, well, hang on, take responsibility. So I'm not sure that we're going to be able to get through that. And I think that's part of, this is me saying, part of the forge that we're probably going to hear about when the 10-year plan comes, that there's going to be a lot less on individual responsibility as citizens, which is what those of us in provider organizations feel and think and think should happen, but a lot more on us to try and drive and improve the offer.
I was just really interested in the digital health and care technology service. Do you think that will lessen the pressure on district nurses or not have an impact?
Potentially. I think it seems sensible to explore that. I mean, what's in that kind of suite of things that are being offered? Some of those things have been around for quite some time. I think the technology is better and there's more of it available. So I think it's the right thing to do. But it's a bit like the discussions we're having with the Living Within Our Means program. Sorry, everything comes back to that. It's you can make assumptions around investment and what the return is, but some of this is new. Some of it has to be underpinned by assumptions around human behaviour, the point that if it's made about, what we as the public are prepared to do for ourselves and what we think other people should do. I think particularly around frailty, there is something about how we engage kind of older people in this. So I think it's the right thing to look at alongside other things. But what we need to probably get better at is just kind of measuring, is there if we do this, is there a reduction in demand over here? Yeah.
I was down in the Woolwich Centre the other day with James, and we were talking to the team about the use of some of the technology. And I think staff have got to be really confident in being able to recommend the technology. So I think that's the real cultural gap. So the technology might be very good, but are staff comfortable and confident in using it and recommending it?
Thank you. And I guess also there's that question of, we often put the technology in a step in the process, which is the same process that we were before, rather than rethinking that process. And that's something that we need to do. And that's, Jane.
Yeah, I was out with the district nurses at Blackheath and Charlton last week, and I was amazed at how many of the team are actually career changers. So they've had a previous career. And I spent a lovely shift with Abby, who has an IT background, used to be a software designer, Generation Z, absolutely wants to drive this stuff forward. So if we can find our people, we can do this. I have to say, those district nurses, they're working flat out. And the feedback from the families was amazing. So I know they're working hard. They need to know that we know they're working hard. But I'm absolutely certain they can take this forward.
Yeah, and I think I'd reflect as well. My meeting of district nurses, just what a diverse group of people they are in their background, both within the NHS and outside the NHS. Probably extreme compared to other sides I meet in that sense, which is really good to see. Aswa.
So it's really coming back to that point about where we do put in new technology or new changes in models of services, just making sure we do the feedback loop of a post-implementation review, because I think quite often there can be tweaks, and we've had examples of that where we have gone back, where something hasn't quite delivered, we tweak it, and then it goes back and it does begin to deliver. So I think we just need to get that needs to become second habit as we're going through all of these things.
So if I could reflect on that one, it's almost the digital way of thinking rather than thinking about it digital, where we make something that's we think's good enough and then we iterate it to be better, rather than thinking that we spent ages designing the absolute best thing, putting it in, and then wondering why it doesn't quite work as well as we thought it would in our beautiful plans. Sometimes we've got to go with good enough and then iterate it to be better. Suzanne.
Surprised to hear myself saying this, but I think there's something about risk appetite here. And I think there's two elements to it. And one is our risk appetite in relation to innovation and what as a board we think are acceptable risks. I think the other thing which just struck me when I talked to the district, visited the district nursing teams, is there's something about their risk appetite as well, in that they feel unable to say no to people who are one.
Thank you.
Thanks. And the example which comes to mind is our district nurses providing insulin injections for people who they don't trust to do it themselves in a timely way. Now, clearly technological reminders can be one part of that, but ultimately it needs us to push back and say, this is not us. Our risk, this is your risk. If you and that, to do that as a trust, we need to be really clear that that's what we're going to empower teams to do.
Thank you, Ian, and then I think we'll.
Sorry, because it is a really interesting conversation, because I think that's a really nice example of what can we expect from the public. So 10 years ago or so, we used to talk about this thing called patient activation. It hasn't gone away, but it's essentially how do we help all of ourselves as the public, to kind of look after ourselves, whether it's kind of, preventing things getting worse or things happening in the first place, or taking charge of our own treatment, and linking this to integrated neighbourhood teams. Particularly, I think, over the last few months, where there's been a real desire to kind of think about how that's organised and the kind of form and the structure, we started to lose that bit of the conversation, which is the reason we're talking about neighbourhoods. Is it's about making the service, making it kind of understandable to the local population, and that's a dialogue. So what do they? So I think there is a way of asking more of the public if they feel it's a negotiation and if they feel that they're kind of shaping what they do. And the whole point that Azra made earlier around kind of health inequalities, we need to be using that geography to kind of speak to communities, to understand from them when they think they're not getting a good idea. So it's quite nuanced conversation, but it's absolutely integral. And if we don't do that, all we're doing is just kind of reorganizing. It's not going to be any different, really.
So I think that this is an area that we've highlighted a real interest in district nursing, which has been also one that I know has predated my advent as chair, when there was a lot of discussion about it. Rather than having a special agenda item, perhaps, Ian, we could ask you in your next coup report to having had this report and had a chance to reflect on this report, if you might include in that how you see this moving forward, this area, because I think this is something that we don't need to have a separate paper on, but I think we need to address going forward. Yeah. Thank you. Okay, we're now going to move on to the non-executive directors reports, and just to remind people and to let Martin know that what we've do here is we talk about the board visits we've done, and what we started doing is, rather than going through them in a list, having each non-executive director who's been on a board visit to talk about all of their ones. I'd ask my executive colleagues, perhaps, who have been involved in Jim and Nina's visits, to perhaps say it, but again, assuming that the papers are read, but to bring out things that are perhaps not in the papers, or to bring out things that are themes that we might take forward. And I'll kick off, and then we'll go anti-clockwise. So I did a visit with Alison. Thank you, Alison, as well, for putting together the paper on this one, to HMPs Rochester and Cookham Wood, which, while they are next door to each other, are actually very, very different beasts in that sense. So Cookham Wood is a relatively it's a new contract, moving from a young offenders to an adult prison, and at the moment we are very well staffed for the number of prisoners who are in that prison, because they are expanding that prison, and so they feel that there's a lot going on. But they are very much in control, and it's not, I hasten to say, not an easy life. They've got a lot that they're doing, but they haven't got that pressure that we will have with Rochester. And I think one of the reflections that we have is that we've got two prisons next door to each other, and there's some, but relatively little mutual aid between them, between our staff, between them. There is some, and there is ongoing work to have a joint health leader of healthcare, or consultation that might lead to that one. There's a consultation ongoing. That might be a way forward. That might not be. Obviously, it's up for the consultation to discuss that. The other thing I'd say is what really impressed me, and again, it's the same question we asked about the rough sleeping one, is that there is a model there as well of how do we support people who are in a community, in this case, the community's prison, and actually the physical healthcare nurses being very confident about doing lots of conditions and not needing to be a specialist, but then bringing in specialisms when they needed it. And if they had a patient who needed certain, I don't know, cardiac support, getting the support and training to do that, rather than needing a cardiac specialist to do that one. And I think that's something that maybe we need to think about more widely. When we go to Rochester, They've had a CQC that requires a lot of recommendations, fairly confident in hand, a massive change going on in Rochester as they are having more sex offenders, prisons going into Rochester. And that's caused, and we were right in the middle of that change, and the staff were feeling a lot of pressure, understandably, a lot of pressure and a lot of anxiety about that change, partly because of themselves, but partly also because of the need to separate out the sex offender prisoners from the other prisoners was causing double working and causing problems with location and so on. They were very, very frank about it. It was a very lively meeting, and they were very able to be very honest about some of the pressures they were in. But they were clearly feeling under pressure at that time, and several things were going. My other reflection as well was that there was also some innovation there, and talking to the pharmacist there was some issues that they saw about their software, which they reckoned could save them an incredible amount of time. And my reflection is not on, is that possible, because that's now been escalated and it will be discussed, but actually how do we help the people who are leading services on the ground actually escalate that without it necessarily being a board visit for them to escalate it? That actually, that I don't know whether there is a solution or isn't a solution. That's almost not the point. There was a problem that they identified that might have a solution, and how do we encourage them to actually raise that and bring that forward? And I don't know the answer to that, I must admit. I think that's something we've really got to work on, that culture of getting that ability down to the ground to innovate and say there's a problem here. Iffy, I see you itching to come in.
Just whispering, ask Iffy. They do this all the time, where people just send me an email to say, this is the problem, what do we do?
Yeah. Yeah, so we might use a sort of an Ask Iffy type approach for that one, and try and get that culture of, actually, is there a problem here? Because it seems to me that this was actually quite a straightforward problem in terms of saying, yes, this is a solution, or no, it's not a solution. It's not clear to me whether it is or it isn't. It's outside my expertise. Alison, anything I should add there? That was no. Thanks. I'll go around. Damien, I don't think. Yeah, sorry, Suzanne. Pick a microphone, any microphone.
I just wanted to ask about the shift towards taking sex offenders in Rochester, because I think that's not a minor thing. And I would hope that HMP has been training adequately the staff that they have, because the last time I went on a prison visit, what really struck me was how many new justice staff are young women. It's really striking that that's where they're recruiting them, and that has some real implications if you start to include sex offenders in your cohort. So there was that, but I'm also thinking back to the issues that we've seen ourselves with people being groomed by the some of our own patients with a sex offending past, and I just wonder how much is being done to ensure that there are not issues emerging from that change.
And I think adding to that one as well is triggering of old traumas in some of our staff, or some of the prison staff as well. I think is an issue to be added to that one. I think those are all about important points. I don't know whether. Do you want to say something? I don't think I think that's something we just need to really consider. I mean, I think my reflection on it, and having seen more prisons now, is it's very dependent upon the relationship between the governor and the healthcare staff. And on the whole, the relationships are good, but in some cases they're excellent, and in some cases they're less good. And the trouble is, it's always difficult to come in on a one visit. But I would say, on my one visit there, and also in the middle of a period of change, when there always is going to be the staff always are going to be concerned right in the sort of 2 weeks into a change period. My impression is the communication wasn't as strong between the prison and our staff as would have been optimal in that case. But that's an impression rather than knowledge.
I mean, I think the change of cohort at Rochester was something that was planned as part of a kind of strategic relook at Rochester, given kind of recent inspection results. I don't know whether that will lead to a wholesale change of the prison cohort or not. I'm not sure. I mean, we do have experience, as you know, as you've already referenced, Suzanne, of working with sex offender populations, but that's usually in situations where they are the only cohort. And generally speaking, prisons with that cohort have less indiscipline, but there may be other forms of behaviour which you're kind of alluding to, which needs to be kind of managed. But I'll make sure that I'll speak to the kind of local team to see whether there's further support we need for the staff there.
And I guess I do want to be very careful, because I think, we did see that prison right in the middle of the change. And so one's got to be careful not to extrapolate from a moment in time. But I think it's reasonable to say that moment in time, it would be worth checking in and see how they're doing, I think would be good. Okay, going around the room. Damien, I don't think you've done a board visit yet because you're just about to start yours. Sophie.
Okay, yeah, this one is working good. So I'm going to report on, well, got two reports here, which I'll take as read. There are three services that work very closely together: the crisis line, the Bexley Home Treatment Team, and the AAA team, which is the Assessment for Admission Avoidance, which I always write down because I forget what AAA stands for. But just taking the wider themes that emerge, these were really interesting visits. The crisis line is a 24-hour line, so that puts on a particular kind of pressure on our staff. But what was really interesting was to reflect on the form of communication. So it's a telephone line, and that brings its own challenges, but also some really interesting wider learning. I was reflecting on how much of Oxleas depends on telephone calls between staff and patients and staff and carers. And this team have been really proactive in learning what makes a good call. And what was really interesting was the tone of voice. So they listen to the recordings of the calls and they reflect on what could have been done better and what went well. And that tone of voice learning, I thought, was really, really interesting, how you can say one thing and it can have a completely different impact the way that you say it. If you say it with kindness and compassion, it can really change things. And I think that had really struck the team as well. So I thought that was interesting learning that could potentially be shared. On the kind of negative side of this, of course, when you're having a phone conversation with someone, you cannot see that other person. And so there is a level of risk that staff felt unable to measure. They didn't want to end the call, was what they were telling us. And that meant that, unfortunately, they experienced high levels of abuse, particularly racist abuse, as is reflected in our staff survey. And quite often, they felt unable to end the call because they didn't know who they were speaking to and whether they were in the middle of psychosis or whether they were just being racist. And I say that in inverted commas, not to be reductive. But what we were really struck, and it's reflected in the comments here, is that there is no one solution, as we've talked before about similar feedback from across acute and crisis in particular. But this team is working really hard to try and support staff through this. And we know that the Violence and Aggression Subcommittee have discussed this issue. The People Committee are discussing this issue. But it is really important to highlight it because it has such a negative impact on staff, and they really wanted to make the board very aware of this. So that was a particular challenge. Just working with the AAA team, this is something that I think highlights what we were talking about teams working together. And I recall on a previous strategic day, we had a conversation about there being physical boundaries between teams. Well, this is quite interesting because the AAA team and the 111 team are now physically co-located. So they're working in the same place and working together and supporting each other. So I thought that was an interesting reflection. It seems to be going well. And the AAA team have been integrated into the service of the home treatment team. And that is something that has potentially been a bit more challenging because it can be seen that by coming in and performing a service that a team has done before, it could be seen as taking away something from that team and fragmenting it. So there have been challenges around that, but overall it seems to be working well, and there is learning we can take from how you can integrate teams and how they can work together. So those were those three teams. I should also say that the AAA team won Oxleas Team of the Year, and they are very focused on building a fairer Oxleas BAFO. So I think it's really important to recognise that. And there is some really proactive work across all these teams on reducing demand by linking to the voluntary and community sector. There's a lot of signposting and highlighting there. There is a reflection that potentially if the communities were more aware of those services, they wouldn't be coming to the team in the first place, and that would reduce the demand. So Ian and Rachel, I don't know if there's anything you want to add for those three ones. No? No? Okay, I'll just go on then, because we did visit the ECT, the electroconvulsive therapy, and the transcranial magnetic stimulation, the RTMS. Yeah, again, I had to read from that, but that was really interesting visits, because I personally had been unaware that Oxleas offered these services, and as we talked to team members, we found that lack of awareness was actually quite high across Oxleas, and the team are being really proactive to raise awareness, particularly among new members of staff and clinical team members. So really promoting that ECT service, and also from a strategic point of view, promoting it externally. So trying to bring in income. So that was a really important point. And we were able to speak to the partner of a patient who was receiving ECT while we were there. That provided a really interesting perspective that I hadn't realised before. So unless there's anything to add, those were my visits.
I was just going to advise the board that there are conversations going on about merging the crisis line with the NHS 111 Press 2. I think we're going to be looking at a business case as part of the SLP on Tuesday, and I hope that at some point I'll bring something to the board to keep the board informed.
Yeah, I was just going to add to what Sophie said about ECT. So, I mean, it was an incredibly positive and affirming visit, and I think it's an interesting one because it is a service that, or a treatment offer that is quite polarizing, and I do wonder whether that's then led to it having a kind of fairly low profile, but having that validation, I think, from a partner of a patient, you can really see how it is something that should be part of our kind of repertoire of offers. Really, the issue for us as an organisation is that there are very not strict criteria, but I think there are criteria for its use, and because of that, it's a low volume service. So I think we are, again, going back to living within our means, really trying to look at how we might market it further and kind of position it as a kind of system offer. But the quality of what they do, and particularly from a patient experience point of view, is fantastic. Yeah.
Might just quickly add to that only a few days ago, I think it was, I received an email from the father of a patient who has just completed ECT, thanking Oxleas, thanking the staff, and really singing their praises. And did say that his son is thinking about coming back to work with Oxleas, as experienced by, live. Yeah, you know what I mean. Too many of these. Okay.
Thank you. And I think one thing we mustn't lose from Sophie's report as well is the help, which I know we're talking about in various committees, is the abuse to our staff and how we help our staff deal with that one. I think we need to think about how we bring that to the board, because I know People's Committee and other committees are thinking about it. So it might be through that route, but can we just make sure that we do pick that up somewhere? Because I think that's that's the one, that's one of the things I think we can shift in our satisfaction survey as well. Suzanne? Nothing. Martin, I think a little bit early.
but can I thank Sally and all the teams that we visited as part of our induction, Damien and I, yesterday. It was, I think the term whistle stop was used a number of times, but we went through all 3 boroughs into a number of services, and a lot of the reflections I've heard here in detail were reflected in our very transitory visits to meet staff, who were all brilliant.
Thank you, Anita. Do any of the Neds want to comment on the visit they may have done with Jim or Nina? I don't think so. No. Okay, let's move on then to the delegation of the annual report, etc.
Thank you. So there's work taking place at the moment to complete the annual report, drafting the annual accounts, quality accounts, and look at the provider self-certification. So this paper is asking the board to delegate the signing off for the annual report and accounts and self-certification to the Audit and Risk Assurance Committee, and for the final version of the quality account to the Audit Committee. So if you're happy to approve that, we will take that forward. Thank you.
And I think, as I think I signed the certificate, don't I? I should attend that meeting too, as well, as a guest. Thank you. Okay, we now go through the committee meetings, and I'll ask the chairs to comment on them. Again, assuming the papers are read, but to bring out what you see are highlights or themes that you want us, that you think should be brought to us attention. So I'll start with Suzanne and the Quality Committee.
Oh, you've caught me on the hop again, because I was expecting me to have a break for lunch before. So I think the key thing that I wanted to highlight, because of your comment, Iffy, about searching for excellence, is that I think that we received the regular 6-monthly feedback from the ALD Directorate, and there's some absolutely brilliant work going on there. And one of the items that we wanted to explore but didn't have time to explore was their new initiative on menopause care for women with learning disabilities. And one of the reasons I think that's really exciting is that it's such a new area, partly because the life expectancy of women with learning disabilities hasn't offered itself in the past to this kind of work. So it's really brilliant, I think, that they're taking that on. It's an under-researched area and a piece of work that they're just starting. So I did want to highlight that. You know, there were lots of other things that they reported, but as a whole, as a directorate, they're doing fantastic work. The other thing that I did want to just draw attention to was at the end of the report, or rather the advised bit of the report, we had 2 improvement focus bits to report. One was around the rapid tranquilization, which there's been huge improvement here. And I and other people are quite fond of saying that you don't improve a pig by measuring it, but there is no doubt that there has been a lot of improvement on rapid tranquilization, because we are measuring it very consistently. And so I think it was really good to see the outcomes of that. The other thing which was very exciting, and it comes back to living within our means, was the value improvement pilot that was done with the Greenwich Frailty team. And you know, more can be said about value improvement than I'll say here, but I think if we just look at some of the outcomes of that you know, the idea being that you look both at value and at quality improvement at the same time, and the approach has a really energizing impact on staff who are really up for it. So you know, we asked, you know, where this could be done next, and if you'll note that that the team is going to look at doing some work with prisons and the tobacco dependence team. So I think that, you know, hopefully this will become a way in which we regularly introduce value improvement methodology. And the last thing I wanted to mention were the squad goals, because you will no doubt hear more about these. So the squad, which I blame Vicky for inventing this, they're the strategic quality and directorate goals. And the important point is that the quality goals are being linked very clearly to the strategy. And there's been some very good work done with teams to help them to understand how the strategy impacts on their directorate, on their team, what they want to aim at, so that there's a real integration and a clear embedding within the teams of quality and our strategic aims. So I think you'll be hearing more about the squad goals in future.
Thank you. The Quarter 3 report was reviewed at the Quality Committee, and I think our key discussions were really around a leader case review, which had highlighted some inequalities in screening. I'm pleased to say there has been some really good system learning that's been well received by our GP colleagues in the area. But one of the discussions that we focused on was around the recording on the death certificate. This is something that we have been highlighting for many years, and I just wanted to add the clarity around what should be on part 1 and what should be on part 2 in terms of cause of death and contributory factors. There wasn't really anything else that really came out of the committee following those discussions.
Thank you. And I thought that was a really good thing of us working in partnership, though, providing some leadership to places. I thought that was, I mean, a sad case, but a good, a really good report on it. So thank you. Business and infrastructure, Aswa, can I turn to you?
So I'm going to take the report as read, but I am going to give some updates because time has moved on. So it was a very busy period for the business and infrastructure. We had 2 special business and infrastructure committees since the last board. One to consider the annual plan that we had for 25-26, and that meeting was open to all board members. And I'm just going to draw you back to the attachment on the Chief Executive report, which effectively then has just given a copy of the board assurance statement. Since then, so that was the 27th of March submission, we did resubmit a plan at the end of April. It was very minor changes, one just updating the cash position, so we didn't feel that needed to come back to the board. And the second, recognising that there was a triangulation between what providers put in for their income against commissioners, and because of all of the movements between contracts, between commissioners, we had to just adjust those. So they have not changed the total income, just simply the source. Those were the only 2 changes. So the board assurance statement still holds true for every other aspect of that plan. Second area then was we have now closed down 2024-25 and submitted our set of accounts. In for that, the final position was a £2.7 million surplus against a £2.5 million, which is what we'd said to the system that we would provide, and that's against the figure that we then have. That's the figure we're assessed with against NHSE. You'll have seen within the report, we've talked about the fact that we'd had all of our assets revalued. We have to do that every year. That had resulted in a write-down of our assets. So when you finally do see the annual accounts, they will show a deficit as that figure has been put through, but that is the impairments. That is not how we were actually assessed on our financial position for the trust as a whole. And that effectively was an £11.5 million write-down of our asset values. And therefore, we will be showing bottom line on our statement of income position, £9.6 million deficit. But as I said, 2.7 is the figure to keep in your heads of the surplus figure. You'll see within the report that we've referred to the fact that the CDC on this site has not gone live in its totality, but just to reassure the board that all of the fixed costs that we could not get out of effectively paying because we've now gone we've finished the piece of work on that site, we've managed to negotiate with the help of Rachel's team and finance that we're covering off all of the fixed costs of that area, so we're not incurring any ongoing costs from that system development of the CDC while we're waiting to see how that then flows through. There were a number of bids that were undertaken and signed off during this period. One was we put in a bid for the MSK Greenwich services, and that went through. We also had put in a bid for the LPP with SLP. That service had gone through, and we'd effectively been given a direct award of that contract, which is it's a kind of an extended contract from what we had previously been providing. The paper does say that there will be a delegation, or there will be a report that comes in part 2 around soft FM services. We are still in a process of negotiating exactly how we are going to deal with that. So that has not arrived in part 2. That will come to the July meeting rather than the meeting that we've got here. And then lastly, there will be a paper in part 2 where we'll be discussing the Heathview position on capital. And finally, just to give the final position for South East London, we did end up the financial year for 24-25 at a break-even position across South East London. That was with the £100 million deficit that we had been given by NHSE. And the capital position had improved from the month 11 forecast that you would have seen in IFE's report to a £7.5 million underspend on capital, which is significantly better than what we were previously forecasting. And that was effectively driven by the fact that we used less for capitalised leases in 2024-25 than we'd originally planned for. I was going to leave it there and just check and see if there was any questions.
Questions or comments? Apart from the fact I think we should use this to note as well the Joe's sort of immense contribution to BIC down the years. It would be very good to do that. Questions or contributions? I mean, I think the CDC, can you assure us that as well the the depreciation costs and so on are also covered by the current rate? So for us, while this isn't an optimal position to be in, it's not a disaster to us. Great. Suzanne.
I just wanted to ask you to remind us what the PIPE project is, given that they've been commended for reducing racial health inequalities.
I'm going to hand that over to Ian.
Yeah, I mean, this is the PIPE service that's provided within prisons, within some prisons. So it's a psychologically informed approach to people who have personality disorder. So if you, for example, if you go to Swaleside Prison, there is a wing that is effectively run almost as if it's like a therapeutic community. We also have a kind of, and that's the contract that has been re-awarded, and it operates in a number of prisons. There is also a community element of that, which is a separate contract for which we're the lead provider, but that's a London-based service. Yeah.
Thank you. Rachel, can I ask you to do People's Committee?
Yes, so in Nina's absence, you're going to have a bit of a Rachel double act, if that's all right. So I'll talk to 3 points. So on the staff survey, you've got the pack that was presented to us by our external provider. We've identified a range of areas that we want to improve, which include around discrimination, sexual safety, burnout, reasonable adjustments and flexible working. And they are all part of our new people strategy. So it's informed our new people strategy, which we will be bringing to a future strategic exec. So there's a lot we want to work on, but there are also some good things to celebrate in there, and we are being invited to share our practice in a range of different settings across the region. Also, we discussed at the last board, didn't we, about values and whether we're living values as an organisation and what the staff survey tells us about that. And we're going to take a paper on that to the next People Committee in response to that board discussion. Also want to highlight all of the work that's going on around sexual safety, which is a really big kind of thing that we're focusing on as an organisation, and that will be overseen by People Committee, but we'll be keeping Quality Committee involved as well. And I also wanted to highlight the work that's gone on to really reduce our agency over the last year. We've made some really good progress there, but we are going to need to do that all over again next year as part of that little known Living Within Our Means programme.
And I guess that's going to become more and more difficult as we've probably now got, I'm assuming, high cost, rare people occupying agency positions.
I think that's right, but there is a golden moment now to be getting our agency, people who've worked with us for a while as agency workers, to come onto bank and to substantive roles, because everyone is cracking down on agency. So previously, I think people could have said, well, if you're not going to take us, we will go elsewhere. And our staff and managers were rightfully kind of worried about what the impact would be on quality of care. Now feels like the moment to hold our nerve and really have those conversations.
I think that's the case. My observation from other trusts that I'm involved in is that it's important that the people who would be using those agency staff are holding a common line on things. And is that the case, broadly speaking? I'm sure there are exceptions, but broadly speaking.
We've got an agency reduction programme as part of the Living Within Our Means programme, which we launched yesterday. And one of the elements of that is going to be a toolkit that all of our managers can use to have those conversations. We've already started with district nursing, an area where we were using a lot of agency, and people are starting to see that movement of people over from agency, both onto bank and to substantive roles.
Anita.
On the staff survey, the questions we have around discrimination that we need to tackle, what do we mean by discrimination here, or what do we think the staff understood? Is it abuse where staff are confronted with pejorative terms, or is it something more, we feel like we are more likely to get a complaint, or our advice was not followed, or someone asked to see another clinician? Which of the two is it, and do we know what the staff understood it to be?
The questions are different according to whether it's discrimination from colleagues, so from managers and people within the organisation, and there are separate questions about what people receive from the public. And I think both are areas that we want to be working on. It's always difficult to know what's in people's minds when they tick those boxes. It's also interesting to contrast the results there with the fact that our rates on us being an inclusive organisation that cares about difference are really quite high. So it's kind of what's not translating into people feeling discriminated on a day-to-day basis. We have a big programme of work in this space, as you know, that's really informed by our staff and by our networks. So I think what we can do is to just continue to work on those areas. We know we need to reduce the abuse that people experience. We also know that in some areas we can't completely eliminate it. So we need to make sure that those people feel heard about their experiences and supported in relation to it. So I think the short answer is it needs to be a kind of a menu of interventions for those sorts of elements, because people are experiencing concerns from their colleagues and also from patients.
I think that's understood, but for patients, from patients, I think it's also helpful to understand whether that it is, the concern is just abuse, or it is the clinical interactions as well, because I see this as two separate problems that may have different responses. And I know we're planning a lot of interventions, but are we, for patients, understanding what the problem that staff have identified? We know about the abuse, but is there another element in there as well that we're picking up on?
In terms of people saying, I don't want to be treated by this person, I want to be treated by another person.
Or we feel like we're more subject to complaints, or we're, or negative feedback or something like that, which we wouldn't identify as abuse, but it makes the experience different.
My view from the discussions that we have, and bring Jane in case she's got a different view, but my view from the discussions that we have at the Reducing Violence and Abuse Committee, where we talk about this, and the settings are obviously very different, so you have very different challenges in different settings. My sense is that the issues that people raise are in relation to abuse, including, which I would consider to include people refusing to be treated by a particular member of staff, rather than something more to do with complaints. I haven't picked up on that, but we can certainly explore that further.
I think this ties in with some of the work that Neil and Abby and I have been doing about vexatious complaints about some of our staff. I think there are some patients that take this one step further, and I think that's something that we need to be supporting clinicians with really carefully. We're seeing it growing, so we can tackle what is clearly unacceptable behaviour for people, and that happens. Sometimes people don't exhibit the behaviours in the way that you would normally think abuse would manifest itself, and I think that's the challenge that we've got at the moment.
Thank you. Any other questions?
I take the health and safety part. So there are two issues that I just wanted to highlight that we discussed at the People Committee. The first was in relation to deliberate fire setting, which we have seen an increase in over the last year. It doesn't seem to make us an outlier compared to other organisations, similar organisations, but for us it's quite a significant increase because we've gone from 3 one year to 10 last year. So we've reviewed the fire management framework. We're content that that's robust in terms of fire risk assessments, drills and training, which is a much better position than we had previously. Much better position than we had previously when we didn't have a fire officer. So he's done some sterling work over the last year, and our focus is really very much on search. This particularly relates to acute and crisis, who have a risk on their risk register in relation to this, are very focused on addressing it with oversight from the exec. So we'll keep an eye on that one. And then the other one was in relation to the quality of risk assessments. So we are proposing a new risk in relation to quality of risk assessments, which has been highlighted largely due to the involvement of health and safety managers in undertaking the audits over the last year, which has demonstrated that the quality is not as it should be in all cases. So we're doing some analysis of that to share with the committee and with the exec, and we'll come back with a proposal about how we address that over the coming year.
Thank you. Anything else for People's Committee? No, in that case, Damien, Audit and Risk Assurance, please.
I'll be brief. As Rachel said, we looked again at risk assurance in the context of fire risk across our activities, and work is ongoing to provide more assurance to the board on that. Other than that, we approved 3 programs or projects. The first one is the external audit plan. Grant Thornton, our statutory auditors, are starting to work on the 24-25 accounts, and we approved that plan. Nothing specific to report there. We approved the 25-26 internal audit plan, which contains a number of projects as well as a reserve list in case there are opportunities to do more. The Audit and Risk Committee had contributed to the discussion with a brainstorming session earlier in the year. And finally, we approved the plan or the direction of travel or the work plan for the counter-fraud specialist function, which is run by KPMG, pretty much the same as for 24-25, but nothing else to report.
Thank you. Questions on Audit and Risk Assurance Committee? Thank you, Damien, and thank you for your lot of work summarised in a short period of time there. I'm going to quickly report on the Council of Governors, which I chair. The meeting was held actually in the local hospice with an example of working closely with our partners and part of the idea of showcasing our work with partners. And I think perhaps a highlight of it in many ways was the joint presentation made between our staff and the hospice staff, showing how they work together. And I think in a very effective way. And again, the effectiveness, going back to a theme that perhaps we've picked up from from the presentation, our first presentation this morning, is around talking to each other. That seemed to be the most important bit of it, that there were good relationships due to talking. Other than that, I think the thing that I would highlight is actually in the upcoming governors' activities and things, just the wealth of things that are available for governors to participate in order to understand the trust better and to be able to carry out their role. I think everything else is as laid out in the report. Okay. So in that case, I want us now to last items before we finish this meeting is just to review how this meeting's gone. Do we think we have added value to the work of the trust this morning? And Alex, this isn't your formal report, but feel free, as a spectator, to say anything in this one, because you've been listening in, obviously. But I don't, obviously you're going to do it formally elsewhere, but do feel free to comment on this. Do we feel we've added value to the trust? Is there a way in which we could have done more in this meeting, which would have added more value to the work of the trust and helped the people that we're serving better? Any thoughts around the table? And Martin, again, as a new person, you will have a fresh perspective on it, which might be helpful to avoid groupthink.
And given no time to think about a response,
of course,
I can avoid that too. So I think we'll get another independent objective view more formally, but it's really interesting how much time has been spent talking about actual services and the people who use them and the staff who deliver them. And I have watched we record these things and you think no one will ever watch them. I watched the whole one, I promise you, before my interview. And that came through again there as well. And I think that's really refreshing. The one thing that bothers me as a clinician and a member of the community is that this organisation is focused on the people who need the services we provide. And it's clear that that is the focus of this board meeting. I think the other reflection then comes to the point I made about integrated neighbourhood teams, but it could be other parts of change in the strategic landscape, is how do we make sure that we align what we do day to day with the changes that are inevitable ahead. And it goes back to the 10 years forward view, and how do you do that? And I think there's more to be, for me, to understand about how to do that.
Thank you, very helpful. Any other comments around the table? Sophie?
Yeah, just picking up on that, I think that's a really interesting reflection, because we do have to focus on the here and now, but we don't take the time to think ahead. And I'm particularly thinking about the impact of the pandemic on children and young people. We could potentially have spotted that, not us as Oxleas alone, but there's a lot of missed opportunity there. So I think it is good to keep that front and centre and try and give a bit of time to thinking about 10 years down the line. What will it look like and how can we be ahead of it?
Iffy.
Unusual for me, I think, to feedback, but there are three things that have struck me this morning. The first, of course, is that I like to think that as a board, we've increased our understanding of what's coming down the line, NHS, DHSC, society at large, and some of the thinking of how things will go. But I think what else is also really interesting about that is that we are thinking about the opportunities in that. So we're not sat here thinking, oh my God, it's all terrible. How is this going to work out, right? I certainly got that sense from the board, which is very reassuring. I was also particularly reassured by the balance that we've also looked inside, tried to make sure that we're delivering care to people who need our services, and also we're looking after our staff. And Chair, not to butter you up, I thought the reflections was really very helpful. Just hearing what people have on their minds. I really found that incredibly useful. And not to over egg the point, just hearing colleagues talk about living within our means as something that they see as stuff they really need to deliver on over the coming year is so reassuring, because there are lots of great things happening, but we've got to make sure staff remain our strongest point, but also delivery of care and the feedback we get about the quality of our care in spite of everything else going on, including the money. So it for me, it's been a really good session today.
So thank you. Any other thoughts around the table? Yeah, if you wish, please do. I don't wish to force you.
It's been a privilege to be here and observe today, and the strategic framing that's done for the board is really helpful at this time of uncertainty, and I think that has opened up some excellent discussions where I can see at the heart of the board is what are we doing for our staff to enable them to provide the best possible care for our communities. And right through the conversation, you can hear the depth of grounding that the non-executives have in terms of their service visits and understanding of services and impact on people, and a really good conversation across non-executive and executive around that agenda. So you're also very open about what you want to improve and where the board needs to focus its attention around equity, around things come through the staff survey, around experience of patients. And I think this has been a really mature, future-focused conversation. And at a time of uncertainty, it's great to see this board really clear about where it wants to leverage its expertise, its capacity, its service offer to the communities in the future. So really enjoyed observing and listening. Thank you.
Thank you very much. And I also want to assure you that we are a learning organisation. So any feedback when you come to the written report, we will take it on board, because we always want to improve. But thank you for that feedback. It's also useful to hear how things are landing, which is good. Thank you. Right. Thank you, everybody. For those who have to attend the Part 2 meeting, I certainly think I need some sustenance now. I'm going to stress, to me, it looks as though the Part 2 won't be very long. But so I'm going to wonder whether, because execs and things and other people will have work to do, what would people say if we had a half-hour break and then could take sandwiches into the Part 2 if you were still eating them? Does that feel okay? So we'll break for half an hour, and then you can carry on with sandwiches at your desk after that one, and we'll do the Part 2 in 20 minutes to 2 then. Okay, thank you, everybody.